So let's say, Dr. Ahmed, if you did find a patient that meets criteria, has maybe lower risk disease, as well as low volume disease, and they do want to pursue de-escalation treatment, perhaps at the 2-year mark after metastasis-directed therapy, what real world, I guess, improvements, if any, in quality of life, do you see our patients experience? And also, what does the conversation in the clinic look like when you're talking about de-escalation?
Absolutely. I think, for the large majority of my patients, when they stop treatments, within a few months, they'll start feeling a lot different. They'll feel more like themselves again. They will have more exercise capacity. If they have been deconditioned, they can start working on that, and that kind of improves as well. Their chances of having falls are also kind of reduces. And so patients are usually very thankful to be off of treatments. They are a little anxious about the PSA, so we are kind of monitoring that PSA very closely during that time. But yeah, there are huge quality of life benefits when we end up stopping treatments for those patients.
Yeah, I think that's a great point to highlight, just a quality of life aspect, because I think if you're looking at the community or, even individuals that don't treat or use ADT too much, I think they look at ADT as definitely a less toxic regimen than chemotherapy, which for the most cases I think is true. But we do know ADT is not benign. And like you highlighted, their fitness levels, their energy levels can decrease, erectile dysfunction, hot flashes, maybe interfering with their sleep quality. So it really does, affect our patients' quality of life and their day-to-day activities. So I think if we can find a patient cohort that we can utilize de-escalation strategies safely without undertreating them, I think that is definitely a reasonable approach.
Yeah, absolutely. There's also, patients where their cognition, improves
Very
after
true.
being off of treatments. And I have noticed that if they've been on the long-term, 6-month Lupron doses, that takes longer to kind of come back. The quality of life takes about 6 months to a year to kind of improve afterwards. Whereas if they're on, the 3-month dosing or sometimes on relugolix, that they tend to kind of recover the side effects that they were experiencing sooner than that.
Yeah, that's a great point. I personally usually utilize the 3-month dosing, but if you're saying that you're seeing more toxicity with the 6-month dosing, I think that's very interesting, and that could also be a discussion. But seeing patients maybe in more rural settings that do have to make those larger commutes, and perhaps 6 months, dosing might be more convenient. I think that's definitely a discussion to have with them.
Yeah, I don't think necessarily that the 6-month dose has more side effects, but they are more sustained. And so those patients will just take longer to kind of feel a change after stopping treatments.
That's true. And I think it's also important to highlight that, of course, there are a lot of patients that will want to de-escalate, but, we do have a handful of patients that, are very anxious to de-escalate therapy. They might have more worry or depression off of therapy, thinking, can my cancer come back? When will it come back? So I do think it's going to be discussion, a detailed discussion with the
Yeah.
patient regarding
Yeah,
the
there are
risk and
definitely those
benefits.
patients who are living PSA to PSA, right? And
Definitely.
so we counsel them, we reassure them, and I think every time they see their PSA, they're reassured by that. But it is also important to kind of tell those patients that, this is a long-term game that we're playing here. This is a marathon. In the grand scheme of things, we have a lot of treatment options for them down the road. And as time goes on, there are going to be even more treatment options as we have more clinical trials going on. So I think that kind of discussion with my patients, they really appreciate to understand that this is not, if the PSA comes back, it's not going to be the end of the world. They're going to have a lot of tools to kind of treat their cancer with at that point in time.
I completely agree. I think the GU field, specifically prostate, I'm a little bit biased, but it's a very, very exciting. So I think it's a very positive field for patients.
Absolutely.
So now let's, pivot a little bit. We can talk about how we are identifying patients with the oligometastatic disease. With the rise of the advanced PSMA PET scan that you discussed earlier, I'm sure we're all familiar with that. But we now have a more sensitive tool for really detecting truly oligometastatic disease patients. So I guess my question for you is, how has the availability of PSMA PET scans, which we commonly do at Emory, really impacted your approach to de-escalation of therapy, as well as how do you really utilize PSMA PETs in today's clinical practice?
So I usually use it up front before they've been treated to kind of identify where their disease is at. And then, that helps targeting that disease with MDT as well. So that's very beneficial. There are obviously, sometimes false positives with PET-PSMA2, especially in the bony sites. You
Yeah.
can have fibroosseous dysplasia. So important to have, be working with, radiologists who understand that, so that we're not, doing needless treatment to a lot of those places. But yeah, I think, I use it up front quite a bit. And then, for monitoring afterwards, if they end up getting undetectable PSAs, then I will not use it for monitoring afterwards, or I won't be doing PET PSMAs at the time that we are de-escalating either if they have an undetectable PSA, because I don't think that that really changes the question whether we should de-escalate or not. But when the PSA eventually rises back again, once it reaches zero point 0.5 to 2, that is when I will then start thinking about getting a PET PSMA. And, at PSA of zero point 0.7, zero point 0.8, we oftentimes will find one or two oligometastatic sites or local progression. And sometimes we have, options at that point to address it so that we can delay ADT as much as possible for patients who've had side effects from ADT. For those who've not had side effects, you can then supplement with ADT with the MDT at that point. Usually, I'll go with the shorter course of ADT at that time. But then, you can go back to watching the PSA again. Now, sometimes, patients do develop diffuse metastases, and I think the timing to PSA recurrence is very crucial in understanding, how much to ADT to put back on, how long to be on the ADT afterwards. And I think if they have a brisk progression, I will typically, put them on continuous ADT with hormonal intensification moving forward.